everybody's busy, so sometimes people pop in a little bit through the meeting because they get off other meetings or off clinic or whatever. Um, but with a couple new folks, we can definitely go around and just kind of introduce ourselves. So, my name is Jay Robertson. I work over at Children's Mercy um, Sports Medicine Department. I work out at Blue Valley, mostly 135th and Metcalf, but I am the healthcare sector lead. It really should be the co-lead because Katie does most of the work. And I been at Children's Mercy for like I don't know 15 years. Been doing KCPA plan since the beginning, so like 4 or 5 years now. I can't even remember. But yeah, so this is the healthcare sector meeting. Uh, Katie, you want to go now?
Yeah, sure. So hi, I work with the Lifestyles Collaborative. I help to support different.
Eddie, your volume is pretty low.
Oh, okay. That 50. Is that better?
Much.
Great. So hi, I'm Katie Amy, the Kansas City Healthy Lifestyles Collaborative. I help support some of our various initiatives, one being the KCPA plan. And as Jay put it, I help support our healthcare sector of the KCPA plan. So it's nice to meet everybody. I will go ahead and popcorn over to David.
Hi, my name is David Varan. I'm a family practitioner and professor in the School of Medicine in the Department of Community and Family Practice. I joined this primarily because I've had an interest in remote patient monitoring and patient-derived data, particularly the activity data that comes from mental health that we now can view within our EHR, and I'm puzzled by the lack of clinicians wanting to use it, and also a little bit surprised that so many patients don't realize that the health app can connect to healthcare resources, and so much of our treatment is of chronic diseases, and that's tied into activity and lifestyle measures that we can measure but aren't.
I can jump in here. I'm Josh Holbert. I'm one of the new pediatric cardiologists. I'm a general cardiologist over at Children's Mercy. I'll start here in a couple weeks. I did my fellowship here, and one of my big passion kind of projects is we'll be building a sports and exercise cardiology service. And so I'm getting that up and off the ground. And I'm a Kansas City native, born and raised. And so sports had a huge impact on my life. And so kind of jumping in with the KC physical activity plan and getting involved has been a huge point of emphasis for me. So excited to join.
I'll jump in here. I'm sorry on my camera. I don't know. I got a new laptop and maybe the camera isn't synced to the program or something. I've tried. Anyway, I'm Dan Kane. I'm here in Kansas City, live over in Brookside. I first got involved in this, the project through my activity. And well, I've been in healthcare for many years, 35 plus on the payer side, and particularly in the provider relations and contracting side with all provider types, from hospitals to home and community-based services. But I was involved for about 3 or 4 years in e-bikes, and in my work as a contractor with one of the Medicaid payers, I came across a situation where we were able to provide an e-bike. This was through, now they've changed their name, Rehab Institute of Kansas City. Now they're Abilify. That's what started the wheels turning for me. So, and also I'm a neighbor of Robbins, if that'll give me any street cred.
Well, thank you all for joining us today. The agenda basically the main thing that the three main things we've been working at in the healthcare sector are the Just Walk you might know it as Walk with the Doc. Trying to show some, do as I do with the healthcare workers, and the patients, and that's been, I think, a lot more successful at UMKC with adults than it has been at Children's Mercy with kids and families. But that's something that's part of the healthcare sector. Another piece that has kind of been put on hold for, I think, over a year now, is the reimbursement side. So some of the aspects of trying to get physicians reimbursed for actually spending time talking about this in clinic. And then the third thing we've been working on is the curriculum. So trying to help with the med schools and the residency programs all around town, trying to get more just focus on physical education to the physicians so that they can then educate the families. But we also want to make sure that we include nurses, nurse practitioners, PAs, pharmacists, really anybody who comes into the healthcare system, to make sure that everybody's getting some education on that. So far, we've had some success with KU and UMKC in both the med schools and in the residency parts. And then not as much with Kansas City University, and not really any consistent attendance by anybody in charge of any of the nursing schools or PA schools. Well, the PA at UMKC actually has been, I take that back, that's been somewhat affected. Stephanie Ellison's pretty involved in both the med school and the PA schools, so that's been helpful over there. But those are kind of our three main kind of points of emphasis that we work on through the healthcare sector. So those are areas that if you got ideas, if you got anything you want to bring up or get involved with, then we definitely welcome that. The pair part, Dave White, who's not here, he's a exercise physiologist, so he's been working on that, and it kind of it fizzled out a little bit because it was just so hard to get any clarity on how you get reimbursed. But those are kind of the three main things. So Walk with the Doc, I know, or just Walk as we've ended up calling it, because it's not always physicians there. I don't know if Katie has any big time updates on that. We've tried several different locations and several different ways to do it, with varying degrees of success. So
yeah, there's not a lot to report. Last I spoke, so Shelly Summer, she's with Children's Mercy. She used to work with Kansas City Healthy Lifestyles Collaborative. She's helping us to expand the Just Walk program within employee wellness at Children's Mercy. She's also helping us to set up a potentially new site location with Unified Health. But those conversations are just preliminary, like they haven't really gone anywhere yet. So we're kind of still where we were 2 months ago, is that we're working to expand and include other organizations and partners, but getting it started has just been a bit of a challenge. Hopefully soon we'll have another site location though, and we can share that information. As for UMKC's program, Stephanie Ellison, as they mentioned, lead at Just Walk chapter, and I haven't heard anything new. They still are hosting walks. They are I believe, the last Saturday of the month. I will double check on that and post it in the chat though. And from what I know is that attendance and overall participation from community members has always been excellent. So that's great. We would love to mirror that with our other Just Walk walks. That's it. So if you have any questions or want to learn more or get involved, please don't hesitate to reach out to me. I know KU did used to have a Just Walk program. Last I knew, this was last year, they were working on getting that set back up, but I haven't heard anything about whether or not they've made any that.
and we've tried a few other ideas and spots with it, like doing one out at Corporate Woods. There was initially some interest in doing that, and then no one really wanted to take that on as kind of be the primary person out there because got to have someone on site to do it. So um, that one fizzled out a little bit. We tried with Children's Mercy. We tried doing some stuff over in KCK for about a year, and talking to the schools and the churches and stuff around there, and just got pretty sparse participation. So I think it's worked really well at UMKC when they've had kind of Medicare and AARP involved, really promoting the walk itself. So if anybody's got any ideas like that or wants to add on to what Stephanie's already doing at UMKC, that one seems to be by far the most successful. So, and then the curriculum side, like I said, KU and UMKC have both started putting that into their kind of first, second year curriculums, and they've gotten some, they got some champions over there. We're kind of promoting it and getting it. So, it just starts off a few lectures at a time, a few lectures per year, and I think it grows from there. But I think Stephanie, again, with Katie Miner over at UMKC has done some stuff for the clerkships for the residencies in family practice, with some remote patient monitoring and things like that involved in the idea. So that's actually been funded through the KCPA plan. So we have some per sector, and you can correct me if I'm wrong, but I think like $6,000 per sector, little mile.
So
I know we don't have any more now, but yeah,
it was 15
for this year.
Yep.
15,000 per sector.
Per sector group is
Okay.
what we started off with. Yep.
Okay. Yeah, so there was funds at least, or funds per year, and it just depends, I think, depending on what sort of donations stuff we can get, but to start some implementation projects, and one that definitely took some funding was that family practice clerkship, patient monitoring with physical activity, teaching the patient or the students how to do like a physical activity prescription. And there was some idea, I don't know how far into the remote patient monitoring it got, but with some Fitbits and stuff for certain families, and being able to track things long term there. So those are some of the things that have already started and been kind of implemented. And the idea on those implementation projects that KCPA plans funds, it's kind of a startup cost, and then the idea is that you would get the funding somewhere else after that, eventually, hopefully by maybe the med school or something. But that's kind of where we're at. So first year in that. So yeah, again, Stephanie, she might pop on. She always tries to get on here at some point, but she might have some more information on that. So.
And I'm sorry, James, I can't remember her last name. Stephanie, please remind me.
Ellison,
yeah. Thank you.
Ellison, yeah. And she's always working hard, doing good work with that stuff. And she's an ER doctor over at UMKC. And then, yeah, like I said, the reimbursement part, that's the one that I think, getting some more insight from the payer side would actually probably be helpful. Again, Dave's the one who's been working on that, Dave White. But there just hasn't been much update or change in that over the last year and a half. So
I might be able to leverage a little bit with the payers. I know most of them regionally here, Medicaid and the Medicare, CMS, and as far as the guidelines, reimbursement, modifiers, and I think that's probably what Dave is doing. I'll reach out to him again. I had kind of connected previously, and then
awesome.
I haven't been in contact. So I'll see if we can coordinate with him, and I can get him some answers.
Yeah, that would be great.
Yeah.
I think I just haven't talked to him much on it in a while, so I don't know how much he's still working on that and looking at it. But
Well, I think the reimbursement side of things, the CPT codes and everything are there for physicians to use. The issue has been most of the payers don't reimburse it or don't participate in that, and that's including self-measurement of blood pressure. It's only Medicaid and Medicare now. Most of the others don't, even
Yeah.
though they all acknowledge that it helps. And then there's a whole rash of other types of chronic condition management um, work that does do, but it's pretty labor intensive because you have to record so many minutes per month of gathering data. And while you can put everything in place, when we did a remote monitoring project with Medicare patients 3 years ago, only about half of the patients would actually use the devices we put in their homes for the 16 days or more that it requires to get reimbursement processed. And so it takes a lot of cajoling of the patient. But the one thing that I'm kind of really puzzled about is we've turned on the Apple Health connection, and 100% of the patients that I've showed that to immediately turned it on for themselves and can share data with the physicians. And so there's a rash of data there, from sleep to activity to workouts, you name it. It's all there, including high frequency glucose monitoring if they have a Dexcom device. So, I mean, there's a ton of data there, and 51% of all of our patients at in University Health have iPhones, and yet we're not using any of that stuff. And that doesn't cost anything for implementation. It's there. And so it's crazy that we're not sitting there and discussing that with the patients when we see them and saying, well, you're not getting enough sleep or you're not getting enough activity in any type of stuff as part of the treatment for any of their conditions. I mean, so that's the frustration. It's not the technology, it's the inability, like you say, of making it financially sustainable.
Yeah, there's lots of
Well-
incentives. I think of Medic now on Medicaid, you know, and we're leaning into more of a pay for performance model with, you know, the incentives when they do their screenings, the health screenings, you know, it's and gender and race are also taken into account, and the payment differentiates based on some of the inequities that they're trying to close gaps on. So, but that's a good point. If we could you know, use what's already there, and you know, there is value to it. You do see, you know, the more you exercise and you're active, you know, improvements in your A1C and other metrics that we measure are going to be affected.
Sure.
So,
I mean, we have ample evidence when we give blood pressure monitors to our patients and they actually connect with us and we do it, that immediately we meet the goal. But the problem is, it costs about $100 per person to actually do it. And while we can get to the value-based reimbursement and everything on those few people, we're talking only have the resources to connect up maybe 500 people we've done so far. we got close to 30,000 people with high blood pressure. So we're not making a dent big picture. We
Yeah.
make a huge dent local to the individual, but the will to scale it up. So you're spending 3.5 million on cuffs and connectivity. Nobody's got that will. And yet we know that if we really want to get there, we just have to get our patients measuring whatever there is that's tied to whatever condition they have.
yeah, and it might be an incentivization to the members, you know, reduced premiums and things like that, where they're incentivized. They give, you know, we provide credit cards with $25 to assist them and motivate them to go in and get checked up. So there's lots of levers to pull. It's just aligning them and kind of getting this specific, the specific providers, because most of these measurements are done by the nurses and nurse practitioners, right? They're taking the data down during the visit, and then the physician is reviewing it.
Well, actually, that data is already dropping into the system, so nobody has to record it. Even the patient
Oh,
doesn't
right,
record
yeah.
it.
It's in the record. It's in the
You
EMR.
just you just have to look at it.
Mhm.
So Apple Health can communicate directly with the EMR,
Yeah, absolutely. Yeah. in
and
fact,
when it comes in, does it give you like a summary?
no, it's a big
Say
dash.
average hours
yeah,
per week
it's
physical
a
activity.
it's a dashboard that shows everything from whatever the patient's tracking and wants to share, totally in control of the patient. You can turn it
Okay.
on or off. I can
Okay.
certainly send out a screenshot of this, but we've been trying to get people to use it now ever since, that Apple Health could receive information from just about every hospital out there. But with 2000, with iOS 15, I believe it is, the direction could go both ways. And about, I want to say, only about 300 hospitals have actually turned that on.
I don't know if Children's Mercy has done that, although not as many kids have their own specific device too. But
Children's Mercy has an issue in that, you're dealing with an age group that is kind of tenuous as far as connecting to portals and things like that.
yeah, and we're switching EMRs. So
Yeah, I
Final.
mean, and the problem that we have with Epic, and I deal with Epic up at Mosaic, is that Epic's taking a totally different view. They have not turned on the view of Apple Health, primarily because Epic is working with Apple so the physician can order the connectivity, and they want that data to actually come in so they can actually electronically monitor it. The problem with that is going to be resistance from healthcare organizations that don't want that data in their system, because then they're responsible for monitoring it. So a lot of attorneys do not want that data in the EHR. They want the view as long as it's in the patient's responsibility. So it'll be interesting to see how it shakes out. But right now, the Epic users can't see the Apple Health data.
okay.
Again, what program are you going to? You're moving from Epic to,
Children's Mercy,
yes.
You're going to
going
Epic.
from Cerner to Epic.
Oh, to Epic. Okay.
Yeah. Yeah,
Thank you.
in March, April. So, yeah. But yeah, I think that's super valuable information that that would make it easier for physical activity monitoring. Yeah, like you said, though, as long as the patients turn it on and use it, and everybody pays attention to it. But
I think that's where the future of medicine has got to be, is the measurements of their patient-derived data, right? And we're talking a whole rash of data that currently we can't get in the clinic.
and it's better than an estimate of their own personal estimate of how much they've worked or how much they've eaten or any of those things.
Sure.
But yeah, yeah, if you again, if Stephanie, again, they might be working on some pilot projects there with the devices. I can't. They didn't know for sure if the device part was going to work as well as they had planned, and it just started like a month ago. So we'll see. And then Katie, what else did we have on the agenda? I think mostly we were looking for updates from people, but people aren't here to give updates. There was one thing we're working on, which probably has more to do with the sports sector even than the healthcare sector, but we started at least trying to get some coaches on board for an ACL injury prevention warm-up program, the neuromuscular training is actually what the new recommendation is. We call it neuromuscular training so that people want to do it. I don't know how well that's going to work, but the neuromuscular training to help prevent ACL and lower extremity injuries. We got two schools. Children's Mercy going to try working with Piper High School and Center High School. Of all the schools we work with, those are just kind of the first two we picked because they're both pretty racially and ethnically diverse, and they're kind of different socioeconomic school districts. So we're just kind of see how it could help and how it could be implemented in each group, and whether it's it's better for the coaches or better in like the strength conditioning room or something like that. But we got one coach at Piper who was kind of on board for it, and then the more we talked about how it would take 10 minutes of warm up time, which ideally would just replace their current warm up, which probably isn't any good. He kind of balked at that idea, and so hopefully I talked to him this afternoon and trying to convince him a little bit better. But we're going to send basically one of our physical therapists out there, and she's going to work with the coaches and kind of teach them how to do these warm-up programs. And there's good videos and good evidence-based stuff out there. So there's like 2 or 3 that we were going to pick from. The one that our physical therapist who's really into this, one she picked was actually Football Australia, their warm-up program, because there's good video links and it's pretty easy to set up with just some cones and body weight activities. Over at Center, we're trying to get the soccer coach on board. It's just finding time where we can get one of us there when he's available is kind of been the challenge. And it was more of a challenge because the lawyers at Children's Mercy kept giving us pushback on it for a long time. So when they finally said, yeah, go for it, it was about August 10th, and school started the next week. So wasn't a whole lot of time to implement stuff. So hopefully we can get it done for maybe some winter sports like basketball. And then that's just one kind of hopefully injury prevention, keep kids playing kind of activity process that we get started. And eventually, if that works well at these schools, then maybe we can get out to some club organizations where I really think the prime age for this is kind of that 10 to 14-year-old, early adolescent, so they can really learn to use their body correctly and move their body correctly, and ideally prevent more lower extremity injuries, because there's way too many ACL tears, especially in the young, well, in any age, but it's, every year I just see more of the young ones, more of the 12 and 13-year-olds and stuff, and lots of reasons behind that. But, learn to move your body in a lot of different ways is one of them, because if you've been only doing one sport the whole time, you kind of lose out on some of the natural multi-muscle involvement stuff. So that's one thing we're working on. And then, Katie, do we have any other like big announcements? I think you said, save the date for the September 11th Healthy Lifestyles Collaborative, and that's the Shut Out the Stigma. So that's next Thursday, right? Wednesday.
It is Thursday. So
Thursday.
It is, the KCHLC quarterly meeting.
They're free.
Yep. Breakfast is served. They're at the Kaufman. And I'm going to go ahead and put the link to register in the chat just so we can have an accurate head count. And it is hybrid. So if you can't attend in person, that's okay. We will offer it virtually as well. And we do record each of our meetings.
There's a YouTube channel, right? For all. There's a really good one if you want some physical education literacy for younger kids. Our fellow did one over the summer. I thought that was a really good talk. And then, the culinary medicine. I skipped that. What do you know more about that, Katie? Didn't have.
No, I didn't have time to review that link either. But I can go ahead and post it really quick.
But the culinary medicine, it's kind of part of the lifestyle medicine. So some of the physical activity stuff is kind of we've kind of sort of enveloped it in the lifestyle medicine, and the 6 pillars of lifestyle medicine are physical activity, culinary medicine, so teaching people how to cook and eat healthy, substance abuse issues, mental health, sleep, and what's the 6th one? I always forget the 6th one. I think it's social interaction, maybe. I think those are the 6 pillars of lifestyle medicine. So lifestyle medicine has become kind of its own thing. So you can get kind of, as a physician, you can get extra certification in lifestyle medicine. There's an American College of Lifestyle Medicine. If you're ever interested in kind of getting a little more formal education on any of that stuff, they got a lot of free modules, and they've got a lot of pay for modules and things as well. So stuff that students who are interested, or residents who are interested, can go to the American College of Lifestyle Medicine and pick up some pretty good free information, free education on that kind of stuff.
And where's that held at? You said that's on the 11th?
Yeah, so the Healthy Lifestyles Collaborative quarterly meeting is, yes, the 11th, down at the Kauffman Center, 9 a.m. Not the Kauffman Center, like the one on the plaza, the Kauffman Foundation Center,
over on Troost.
Yeah, no one's getting up on the opera stage and talking about giving a talk, although that would be awesome. That'd be a really good place to have it at some point.
Yeah. Deal.
Yeah, so again, those are some of the project and things we're working on. If you've got an idea, or you've got a way to make some of these kind of goals of the healthcare sector kind of come to fruition, we're always willing to talk and try to figure out how to implement any of those projects or ideas. And Robin's always, he knows a lot of people who can help with funding things and stuff like that too. So even if the KCPA plan can't directly fund it, we can help find people who might be able to. So
yeah, there could be lots of partners with nutrition with a lot of the local markets, particularly in season. The little community markets. We have one. There's one in every area of the city, Overland Park, and we have one in Brookside. The fresh food markets where locally grown. They take, I think they take SNAP as exchange, and maybe do something where you coordinate nutrition with a walk, or kind of integrate kind of a type of a fair or something, to kind of get more interest and activity. And then also the trail and bike routes, in the city, in the urban areas close to where KU and Children's are there on Gillum. There's a great little bike and walk interstate down Gillum right there in the neighborhood. And, events could be used for, these walk or ride events, along with maybe nutrition, and work kind of with the community that's there. I think there's kind of an organization for the, and I can't think of what, community gardens. That's what I'm trying to say. Yeah. Community gardens. And that might be, I think there's funding through probably the county or city to assist with a lot of that. So that might be something to tie in with.
yeah, I think we've tried to make the Hospital Hill Walk kind of around the community gardens there. Yeah, and we've tried to get families down from the tower and stuff like that, and get them walking. And it's been not as well attended as we would have liked.
The Hospital Hill run, was it?
No, not even the Hospital Hill run. Just doing our walks at Just Walk program at Hospital Hill.
Yeah,
That's
yeah.
where we've been trying to do for about the last year, 10 months. And it's, yeah, just the attendance is just not quite what we want it to be.
Trying to get them out the door.
Yeah, it's the hard part.
If you want, I can speak a little more about our efforts in the past around Hospitalville. Because I know I was actively involved in trying to get that up and running by working with some of our other programs at Children's Mercy and along with Ronald McDonald House. So we actually worked with Girls in the Rung to do walkability audits, and we created a walkability map. And one of the key locations that a lot of the girls thought were interesting were the community gardens. So we were using that as our highlighting point to try and get more families involved in doing a walk around the Health Science District, because there's a community garden at Ronald McDonald House, and then they have their Serenity Garden in addition to the Children's Mercy community. So we did try. But as Jay mentioned, like, I mean, it's difficult in a lot of families that do go to Children's Mercy, or the kids aren't able to actually participate, and there are just limitations with that. And I that's one of the main reasons we refocused our Just Walk efforts to employee wellness specifically. But families are still welcome to join those walks. So that information is still accessible. And we actually have 2 walks, one at Adele Hall and then one at Crown Center. So we are still trying to promote those to community members. We're just more focused on employees as well.
You said
We do love
Bell
the
Hall
idea.
at KU.
Adele,
Bell.
did I say Adele Hall?
I thought you
same around
said
the building.
Bell Hall,
No, not
Adele Hall.
Adele.
not Bell. Okay. It's,
Adele
Yeah.
Hall that's the main campus at Children's Mercy.
okay.
Yeah.
I'm sorry.
But I do love the idea of also like promoting the bike path use and stuff like that. And Allison Troutwine, we work a lot with her, and I know that there was recently, I believe last year, they applied for PIAC funding. So over by the School of Dentistry, there's that like blocked off area. They're trying to change that into more of like a community focus, like not necessarily a park, but they also want to something similar, and they want to install what are they called, those bike fixing area stations,
What?
to help promote those bike lanes down Gillum. So I need to follow up with her and see if those are approved. But I do love the idea of what you're saying, Dan, of promoting kind of the bike trails and stuff and using that. It's just kind of figuring out how we can work together to do that. Because one entity alone has not proven to succeed at this point. Yeah. Jay, you're on mute.
Thank you. I don't have any other things on the agenda specifically, but I think, Katie, you probably know the next meeting times at this point, so everyone can have it on their calendar.
So yeah, because we also have our curriculum, we have these different groups that Jay mentioned. We meet like every other month. We only meet as a healthcare sector bi-monthly, so like not as often as we used to at this point. I'm saying this, Jay, because we did talk about changing this meeting time. So yes, I have the next meeting day. It's technically November 4th at 11 a.m. But we do discuss very similar topic areas, specifically because curriculum has been our focus for the last year. We did talk about maybe not hosting either the curriculum as often or the healthcare sector. So we can decide on that as a group, unless nobody has any opinion. We will just make an executive decision, but wanted to kind of bring that up and see what everybody thought. Are we meeting too frequently because the healthcare sector does overlap a lot with our curriculum group within our updates? And I know like a lot of people on right now are our usual participants, so it's okay if we don't answer this right now. You can keep the November 4th date on your calendar. I will send a meeting reminder invite. You might also be getting a meeting invite here soon to the curriculum group if you're interested in joining. So
and we also did a little bit of a survey, right, to see if people wanted to change times or if this was like interfering with
Yeah,
their
that was
schedule.
that was recently because we were meeting at 8:30 a.m. on Tuesdays. No, this is still Tuesday. I'm messed
Yeah,
up
this
this Monday.
Tuesdays. We kept
Yeah, but we switched to
Tuesdays.
11.
Yeah, we were talking about changing times or any of that stuff. If anybody's got any strong opinions, Tuesdays work best for me because that's my admin day. But you know, I can try to be flexible if Tuesdays work horribly for everybody else who wants to come and can't come. So we can change things up as needed.
You know, you mentioned the family medicine clerkship and lifestyle medicine. Angela Barnett, is she a normal member of this group?
Yeah, it's specific. She mostly attends our curriculum meetings.
Oh, okay.
Yeah.
Well,
Yeah.
I'll
She's
get
great.
in touch with her because I teach the medical students on their clerkship on how to do some of this stuff, but not really tied in on a day-to-day basis like she is.
Yeah. They like she and Stephanie and Katie Miner, all three of them basically came up with they had two separate ideas amongst the three of them, and we were like, you guys should put all that together because you kind of have the same idea. So they kind of made it student and resident, kind of the same idea for both.
Yeah, I've got to run to another meeting, but thanks.
All right.
Thank you so much for
Thanks for
joining
showing.
us.
Well, thank you. It's been good information.
Yeah.
I'll
Appreciate
get
you
with-
guys showing up.
Thanks, guys.
Thank you.
Have a good day.
Have a good